what's happening in the public conversation is that critics of the post-Dobbs landscape in pro-life states or states that have laws that aim to increase the legal protections for unborn children, the argument is that these legal definitions or these legal frameworks create concerns and compromise the delivery of, in some cases, the argument goes, life-saving medical care. So in order to keep our conversation at the level of the concrete, we're going to use some specific regulatory language that is fairly representative of what has been criticized and what's been under discussion. We're going to take certain provisions of the Texas regulatory regime for abortion, which, as I said, are broadly representative of the laws around the country, and they have themselves been the focus of recent discussion and criticism. So to frame our conversation and to kind of set the table for our panelists' discussion, I'm going to set forth some statutory definitions from the Texas legal code, and we'll put those up on the screen as well. First of all, we're going to look at the Texas statutory definition of abortion. Abortion, I'm reading now, quoting the Texas law, means the act of using or prescribing an instrument, drug, medicine, or any other substance, device, or means with the intent to cause the death of an unborn child of a woman known to be pregnant. The term does not, and I'm still reading the statutory definition, the term does not include birth control devices or oral contraceptives. An act is not an abortion if the act is done with the intent to A, save the life or preserve the health of an unborn child, B, remove a dead unborn child whose death was caused by spontaneous abortion, otherwise known as miscarriage, or C, to remove an ectopic pregnancy. Elsewhere in the Texas statutory regime, there are definitions of medical emergency, pregnancy, and unborn child. Again, what is prescribed, the criminal prohibition in Texas is formulated in the following way. A person may not knowingly perform, induce, or attempt an abortion as defined above. Abortion as defined above is prescribed, it's banned. And then here come some exceptions. The prohibitions under subsection A, which bans abortion, does not apply if the person performing, inducing, or attempting the abortion is a licensed physician. In the exercise of reasonable medical judgment, the pregnant female on whom the abortion is performed, induced, or attempted has a life-threatening physical condition aggravated by, caused by, or arising from a pregnancy that places the female at risk of death or poses a serious risk of substantial impairment of a major bodily function unless the abortion is performed or induced, and the person performs, induces, or attempts the abortion in a manner that, in the exercise of reasonable medical judgment, provides the best opportunity for the unborn child to survive unless, in the reasonable medical judgment, that manner would create greater risk to the pregnant female's death, or a serious risk of substantial impairment of the major bodily function of the pregnant female. Finally, medical emergency is defined in the Texas law as a, quote, life-threatening physical condition aggravated by, caused by, or arising from a pregnancy that, as certified by a physician, places the woman in danger of death or a serious risk of substantial impairment of a major bodily function unless an abortion is performed. Pregnancy is defined it says means the human female reproductive condition that A, begins with fertilization, B, occurs when the woman is carrying the developing human offspring, and C, is calculated from the first day of the woman's last menstrual period. And then finally, unborn child is defined in the Texas law as a, quote, human fetus or embryo at any stage of gestation from fertilization until birth.
One of the prominent concerns that has arisen post-Dobbs is that the pro-life laws will lead to the death of countless women, especially poor women of color, because it will prohibit the procedure of abortion that is safer than pregnancy and childbirth. We'd like to ask our panelists, what do you make of this claim? Is the underlying premise, which is ubiquitous, accurate? Dr. Calhoun, we'd like to start with you.
Thank you. The problem with, of course, all of the rhetoric is that there really is not good data regarding maternal mortality. That's the first argument. The second issue is that if we really understand about maternal mortality, and that in fact it is increased with abortion, not decreased. If you look at particularly all-cause mortalities across all the spectrum, and you understand that the Black women are aborted at almost 3 times the rate that Caucasian women are, that in fact these laws will actually improve poor women and Black females' lives, because they will actually prevent mortality or death, and they will also prevent the preterm births that are subsequently a result of this, the risks of breast cancer which have been associated with this, as well as some of the mental health issues that are also associated with abortion. So these laws actually improve the health of poor women or women who are financially strained, and in women of color and minority women.
Thank you, Dr. Calhoun. Dr. Rubenhorst, I'd like to throw that question over to you.
Yes, I would definitely add on to what Dr. Calhoun is saying. A couple of points. Number one, the comparison that's made regarding abortion and maternal mortality, as he said, is inaccurate for a couple of reasons. We don't have adequate maternal mortality statistics. We don't even have adequate abortion statistics. And I think that if you look at abortions that are done at later gestational ages, there's data to suggest that they're more dangerous than childbirths or even miscarriages or done at later gestational ages. A more fundamental question, as far as I'm concerned, is that African-American women have both the highest rates of abortion among all the major ethnic groups in the United States and the highest maternal mortality. So it can't be true that abortion reduces maternal mortality. Both of those facts can't be true. You could not have higher rates of maternal mortality and higher rates of Black women having abortions. And I think that that's an important question. If you follow the logic of that statement out to its conclusion, what it says is that, well, if we really want to reduce maternal mortality in African-American women, they need to abort more children. So what percent of African-American women should abort their children? Should it be 20%? Should it be 30%? Should it be 40%? And I think that that's an important consideration. If we already know that 17 million unborn African-American lives have been aborted since Roe v. Wade. So what is more is needed if abortion is providing this benefit to African-American women? What more is needed to do that? The final thing I would say is that we do have good data on what works. We know that the primary causes of death in African-American women are cardiovascular causes. And it appears that for African-American women, there are underlying cardiovascular risk factors which exist prior to pregnancy. Abortion does nothing to solve that. What's needed is preconception care, women being able to enroll early in pregnancy and to be followed throughout their pregnancy, recognizing that the magnitude of the severity of illness and burden of cardiovascular disease is higher in African-American women. And that's a long-term issue that we need to sort out.
Really appreciate Dr. Rubenhart's point that abortion can't be a solution to the problem of increased maternal mortality to Black women. Simply, how can you say to a Black woman contemplating a wanted pregnancy that we have embarrassingly, shamefully higher levels of mortality for women in her situation, but we can help her have an abortion? That's not justice. That's a moment where I think we can find common cause with pro-choice activists by simply saying it's not reproductive justice to say the solution to our flawed medical system is to allow you to avoid pregnancy, even a wanted pregnancy. But I think this question is one that gets asked in good faith, because we know that Black women are at greater risk when they go to the doctor to deliver a wanted pregnancy. They're at greater risk of not being treated for pain when they come in for reasons completely unrelated to pregnancy, greater risk of not being treated adequately for heart attacks. And so really what we're facing is a problem that's not unique to abortion or pregnancy, but it's particularly acute here, which is that Black women patients can't always trust they'll get the care they're entitled to, the life-saving care they need, regardless of what procedure brings them to the doctor's office. We observe that problem here, but it's not limited to here, and it needs a more comprehensive, just solution.
Yeah, I think that's exactly right, that what we're talking about is sort of a enhancement of the medical care that we give to all women, beginning with those who are most vulnerable. Dr. Francis, I'd like to invite you to come into the conversation.
Thank you, Jessica. Yeah, I think the only thing that I would add to that is just that, as Leah just said, I think that abortion has been a Band-Aid that we have placed on a lot of problems in our society. And the problem with having that Band-Aid readily available is that it really de-incentivizes people to look for real solutions to the problems that we're facing. And one of these huge problems, as we've all been talking about, is our maternal mortality rate, specifically among Black women. And they deserve so much better. They deserve so much better than abortion. They deserve so much better than being told that their only option to improve their care is to end the life of their child. But they also deserve very real solutions, and we need to be looking at how we can better care for them, as Monique said, pre-pregnancy, but also during their pregnancy as well. And the only other thing I would add is that we have to look beyond just immediate complications and immediate deaths. And that's what a lot of people focus on when they focus on maternal mortality issues. We need to look at long-term outcomes as well. And what we know from data collected in countries that have good health registries where we can mine the data is that abortion carries a 7 times increased risk of suicide. So we're not just talking about immediate deaths, we're talking about deaths down the road where maybe a woman becomes severely depressed after her abortion and then commits suicide because of that. And the other thing, and this is especially impactful in the minority community, is that we know that surgical abortions cause a significant increased risk of preterm births, which are already higher in the Black community, and that any woman who has a preterm birth has a higher rate of cardiovascular disease and stroke later in her life. And so not only are we causing excess loss of life during the abortion, later in life when she maybe has a preterm birth and maybe that baby can't survive, but then we're also impacting her long-term health. And as Monique said, cardiovascular disease is already higher in the Black community, and then we're just increasing that through preterm births that are related to the abortion. So it really has a ripple effect. And so, I agree this issue has a much more significant impact on the minority community, but not in the way that many people often talk about it.
And I would just in for 1 second to say, one of the concrete things I think we can advocate for that helps women who are vulnerable is the support of doulas, including doulas from their community, covered at no cost to them, so that there's someone in the room who's an advocate for them and their baby, especially when they're facing a doctor who may be dismissive of their concerns or their sense of their own body.
Yeah, and I just want to add something. If you do look at the epidemiology of pregnancy-related mortality is in other countries, and in particular in England, where there's socialized medicine, there's not quite the same history of slavery and so on and so forth. But women of color still have 3 times the risk of dying in pregnancy. So one thing that I think is very important, and I know we want to move on to another topic, because abortion causes us to focus on reproductive health and women in that particular phase of their lives, there are other things going on. And we can't attribute the poor outcomes that we see strictly to the care that's received during pregnancy or even during delivery. We have to look beyond that to a more comprehensive, holistic view. And I think that's getting back to what Carter is talking about. We have to look at what is contributing to human flourishing as a means of really addressing these issues comprehensively, not just in Black women, but in Native American and other minority women, and in Caucasian women who subpopulation does very poorly in pregnancy.
So before we move on to the next question, I just want to make two quick points. One is, which is to confirm what I heard every expert say in response to the direct question that Jess raised, is that it in fact has not been demonstrated that abortion is safer than childbirth. In fact, there's a kind of problem of data paucity and incommensurability that has nevertheless that makes that a false assertion, an undemonstrated assertion. And there's been, and Dr. Calhoun and others have written about this, sort of explaining chapter and verse the manipulation of data that is used to support the false proposition that abortion is safer than childbirth. And it is a ubiquitous claim. You read it in Supreme Court opinions, you read it in media accounts. And so it's useful, I think, and we'll circulate Dr. Calhoun's piece from the Anscombe, the Lineker Quarterly from 2013, and other documents to sort of spell out. And Dr. Shiro has also done a great deal of work. And the second short point I'll make is just how already we've expressed a kind of awareness that the problem here is not merely limited to how do you protect unborn babies from abortion. It is a deeper question. It's to think about the flourishing and success and well-being and health of moms, babies, families, and communities, which I think is something that Dr. Shiro and everyone else in the panel have put their finger on. And I should say that we're just delighted as we could be to have Dr. Shiro with us as a fellow of the DeNicola Center, working on a project called the Women and Children First Initiative, which aims to produce this multifaceted, all-embracing, comprehensive kind of analysis and set of solutions at the level of both research, teaching, advocacy, and social services that will hopefully be a Notre Dame's response to this unique moment. Okay, so next question. Thinking back about the statutory definitions that I just read to you all, many critics have argued that laws like those in Texas use terms like medical emergency, reasonable medical judgment, and those terms are confusing, they're vague, and they will compel doctors to refuse or delay life-saving, health-preserving care in cases such as infection, ruptured membranes in which a woman's water breaks prematurely, even ectopic pregnancies. Doctors, if you could, we'll start with Dr. Francis, and we'd like to ask you to help us think through that assertion, namely, in your reading of these laws, and take concretely the laws that we just talked about from Texas, as a physician who has for years had to operate in a discretionary way, faced with complex clinical circumstances, emergencies, to use reasonable judgment in the face of possible civil liability, or even criminal liability, what do you make of the argument that the framework that these laws set forth cause confusion and doubt, and ultimately delay or even lead to the refusal of giving life-sustaining care or important health care to preserve a woman's serious well-being?
Yeah, so, I think my short response to that would be that any physician who is delaying care in the state of Texas with actually very clear guidelines in their statute is not understanding the law, either intentionally or they're just not taking the time to understand the law. So I think all you have to do is look at the way all of the physicians on this panel have practiced our entire careers. So we have never performed elective abortions. We've never intentionally intervened to end the life of our fetal patient, but we've always been able to intervene to save the lives of one of our patients if we can't save both, or both if we can. So I think what we have to do is look at the way that those of us who are pro-life and the way that we practice medicine make decisions in these difficult circumstances. So with ectopic pregnancy, obviously in the Texas statute, it's clearly excluded. So that law in no way applies to ectopic pregnancy. But, I've heard people say that physicians are having to wait until the ectopic has ruptured and the woman is unstable and before they will intervene. That is not the case. That's not how we practice medicine. And ectopic pregnancy, once it's diagnosed, you treat it. You don't wait for it to rupture. Now, oftentimes you're not seeing the patient until it's ruptured, but certainly if you diagnose it pre-rupture, you don't wait for it to rupture and the patient to become unstable. When we look at things like early rupture of membranes, where a woman is at risk for developing an infection, I told someone recently, my challenge to someone who maybe has done abortions in the past or does that as part of their practice, as they're trying to figure out if they live in a state where this is now the law, my challenge is for them to think about what they do in a situation where they have a patient with a very much desired pregnancy, who finds herself with preterm rupture membranes, pre-viable, who doesn't want interventions unless it's absolutely necessary, who really wants to just be sort of hands-off, expectant management, let's give my baby every chance possible. even a physician who is pro-choice or has done abortions, I would hope in that situation would respect their patient's wishes and allow expectant management. However, there comes a time, and any well-trained, competent physician knows how to identify this. There comes a time when you start to see signs of infection, and you can almost always identify those early signs of infection before a woman would develop sepsis. And when she starts developing any of those signs, and there's a number of them: elevated heart rate for mom or baby, uterine tenderness, foul smelling discharge. There's all of these things that we learn when we're trained in our residency program, that you can identify that she's starting to develop an infection. That's the point that I, and I'm sure every other physician on this panel, then go to my patient and say, I'm very sorry. I know that you wanted to do everything possible to try to save your baby, but we're facing a situation where you're developing an infection that could become life-threatening for you. And now it's time that we intervene and we get you delivered. That is the claim that people, well-trained physicians, don't know how to identify that point is so ludicrous to me. I mean, if that's the case, I don't know that physician should be practicing, honestly. Exactly right. I mean, because if you are well-trained, yeah, exactly, Monique, you know when to identify that. And then in that moment, we can intervene and induce labor. And again, here's another point. I guarantee you that most physicians, when they're in that situation with a patient, don't walk into their patient's room and say, I'm sorry, we need to do an abortion, because they recognize that when you're intervening for an early delivery to save mom's life, it's not the same thing. You say, I'm very sorry, we need to get you delivered, but we're going to do that in a way that respects you and your baby. And if it's pre-viable and the baby can't survive, you can do that in a way that delivers an intact child for that family, so they can hold that child and grieve the loss of that child. So, again, I think it's inherent upon state legislators to make their statutes very clear so that physicians do have good guidelines to know, so that they're not delaying necessary patient care because they're uncertain. But we're looking at the Texas statute in this case. It is exceedingly clear, and it's consistent with how those of us who are pro-life have always practiced medicine. And I don't find there to be any ambiguity there. I just think that some physicians may need to sort of change the way that they think, because their practice might need to look a little different now.
Right.
Byron, do you want to, Dr. Calhoun, would you like to add something?
No, I really think, Christina sort of hit on the whole deal. I always think very interesting that you create a false conundrum. I've told more than one person after I heard this, I said, well, this doesn't change how I practice at all, because I've always practiced this way. We've never allowed women to go into sepsis and try to die. We've never allowed people to bleed to death from ectopics that were ruptured. So from my perspective, it's not confusing at all. And the Texas statute is very clear, as I think most statutes are. And if you're really that worried about it, at some point you need to decide you're going to act in the best interest of your patient, right, and not worry about what a lawyer says.
That's right.
Monique?
No, I totally agree with what Dr. Calhoun and Dr. Francis have said. We want to always do the best thing for the patient, and no one looking in, even an attorney looking in on a case as it's evolving, is going to know as well as the physician taking care of the patient what is going on. And if our job is indeed to act in the best interest of both patients, both the mother and the child, then we have to make the decisions that are appropriate and not think about, as Dr. Calhoun has said, oh, what's the outcome here? You are able as a clinician to step back and say retrospectively, this is what I did and this is why I did it. Just want to bring 2 quick points in here. Number one, I think we act sometimes as though the last 50 years under Roe is somehow just been the way things have always operated in medicine. And that's not true. You have really literally centuries of situations where abortion was completely prohibited. It was anathema, even going back centuries. And even in the United States, in the 19th century and the 18th century, medical societies came out and said, abortion is morally wrong, we won't do it. And in those circumstances, physicians always did what was best for their patients. We've had this disequilibrium under Roe where now, we're trying to go back to that pro-life, pro-woman and child perspective. But in those days, the physicians, I've got a fair amount of gray hair, like Dr. Calhoun also has. The physicians who trained us, they had seen it all and done it all. They did not do abortions. They were able to handle any and all situations that came through. And we now have tools, and this is something that I think that gets lost in this discussion. We have tools that they did not have. The treatment of perinatal medicine, the treatment of the fetus as a patient, fetal transfusions. I mean, it's incredible the tools that we have that even when I was starting out 30 years ago just did not even exist. The last point I want to quickly make is that there is the principle of double effect, double intent, and I think it's important. I think Dr. Calhoun alluded to it and Dr. Francis alluded to it, is that the intent of any abortion is always the destruction of a human life. It is always to kill the fetus. That's why you hear the term failed abortion. Why did it fail? Because the fetus did not die. As in opposition to that, the intent of treatment of a miscarriage or an ectopic pregnancy or an induction, as Dr. Francis was indicating, an induction where the mother's life is at risk, the intent is to save the life of the mother and, as she said, to try to preserve the life of the fetus. And so those are two very different things. And we want to emphasize that that principle of double intent is an ethical principle which should guide physicians in these situations to always try to do the best thing. And I think that Dr. Francis said something very important. You do the procedure in such a way that it dignifies the human body, the body of the fetus, so that the family can hold it. Thanks.
Leah?
I think, and I should say that this is a panel on women and children. I've got a noisy child on the floor around my ankles in case people are hearing the extra noise. So I think these laws are pretty good on paper, and the Texas law you've highlighted, Carter, is strongly and clearly written. But there are two gaps in trust that make it hard for people to assume the law as written is the law as lived. And the first is a real gap in trust between women and their doctors. I think for everyone attending this panel, although we've got some wonderful doctors on the panel, I would bet everyone attending knows someone who's had an unsatisfactory encounter with a doctor, brought up a symptom that was kind of brushed off, had a more complicated condition written off, and then had their situation escalate to a point where they suffered more or treatment was harder because a doctor didn't take the time to sit and listen to them. And I think that's what makes it hard for people to trust, even though the law allows the doctor to treat well before the woman's life is critically in danger. It makes it harder to trust that a doctor not taking the default of abortion will actually be attentive enough to notice that moment and intervene. In my own experience, going through miscarriages with doctors I've loved and doctors I've walked out of the office and decided never to go back again, I've never had my life be in danger because of one of their decisions, but I've certainly felt like the doctor wasn't listening to me, wasn't interested in my experience of my pregnancy, was brushing off symptoms that were troubling to me and not taking the time to explain why they might or might not find them troubling at a medical level. So I think that real gap in trust makes it hard for people to trust these laws. And I think the other gap in trust is for doctors who have performed abortions, whether they've done it incidentally in clinical crisis in practice in a emergency, or whether they're active abortionists who make that their primary area of focus, don't trust pro-life legislators. They read these laws and they think these aren't primarily about banning abortions. These are about arresting doctors. And I think it really takes a lot of personal connection, not just the law, to overcome that gap in trust. I grew up pro-choice, and I certainly wouldn't have seen these laws and thought, there isn't somehow a trick in it. The point of the laws is to punish people. So I think we have to kind of work through those gaps and trust person by person, doctor by doctor. We can't rely on the laws alone.
Yeah, I think you bring up a really interesting point. I also grew up pro-choice. And so I think my pro-choice self 20 years ago would have felt the same way, looked at these laws and thought, who are they trying to trap for giving women the medical care that they need? But if what I'm hearing everyone say is correct, that doctors know that when there is a medical emergency, they know how to use their best medical judgment to intervene before, as Leah said, we get to a tipping point in a crisis. And that what we're talking about is a paradigm shift in how doctors think about the practice of medicine, first in seeing two patients. I think many doctors, you hear them talk about their practice and it's clear that there's one patient that they're treating. And also in terms of being really attentive to those little markers that might be signs that a situation is escalating. So I think that you all really clarified and bring home, and I think the Texas law is very clear on these things. And I wonder if pro-life doctors can serve as kind of a model for what that can look like. You know, pro-life doctors, Catholic hospitals have been doing this work for decades. And that we might look to them for thinking about drafting hospital regulations for hospitals that have previously performed elective abortions. I want to move us on to our next question. A concern that has surfaced in the past 6 or 7 weeks is that pro-life laws will prevent doctors from prescribing drugs unrelated to conditions simply because they might be used in abortion-related contexts. I want to start with you, Dr. Rubenhorst, to speak into that question.
Sure. So I think that I can understand why people have those thoughts, because there are some drugs, and kind of the 3 or 4 specific drugs that come to mind. And Dr. Francis and Dr. Calhoun can certainly, if I forget others, but the ones that come to mind are, for example, mifepristone, misoprostol, and methotrexate. And then in addition to that, there are other drugs that are known to be teratogenic. In other words, they cause birth defects. So it's clear that some drugs that are prescribed in pregnancy can potentially cause damage to the fetus. And the 2 areas that I seem to have heard, and Jessica, you can tell me if this is incorrect or not, were rheumatologists who were prescribing methotrexate, and then oncologists who were prescribing chemotherapy agents. So the methotrexate issue is very interesting. I not long ago read an article by a rheumatologist who herself was pro-choice, but she pointed out the dose that she would be prescribing for a person with rheumatologic disease is quite different from the dose that would be prescribed to, for example, attempt to cause an abortion. And methotrexate is not a drug that typically is used to cause abortion. It is used in ectopic pregnancy as treatment for an ectopic pregnancy. And the other issue that this doctor brought up in her article, which I thought was very good, is when you write a prescription, you usually write what it's for. So if you're honest, you will say, I'm prescribing this drug because my patient has rheumatoid arthritis and she needs methotrexate. Or if I'm prescribing this drug for an abortion, you would say that. And so to me, that seems fairly straightforward. Again, the dosage for the drug, the dosage that would be required to cause an abortion is quite different, substantially higher. And you also, as a matter of good clinical practice, you would write, this is why I'm prescribing this medication. With other drugs, for example, mifepristone, which is being used to treat Cushing's disease, misoprostol, which is used to treat ulcers, again, physicians simply need to be honest about why they're prescribing the drug. And if someone says why you're prescribing it, you have a good clinical rationale for doing that. It's long been a situation where oncologists, especially for specific cancers that are diagnosed early in pregnancy, will go ahead and prescribe chemotherapy. The risk, and Dr. Calhoun can comment on this, the risk is not nearly as bad as it's been thought to have been. And again, years ago, I had a colleague who's very, very pro-choice, and she's a maternal fetal medicine physician. And there was a patient who had very severe leukemia coming in, and it was suggested, oh, she needs an abortion. This person said, no, I'm pro-choice, but even I would not say that. Let's go ahead and treat the patient. And again, what it all comes down to is doing the best thing for the patient. If a physician is not using a legitimate indication or saying, I'm prescribing this drug, I'm prescribing mifepristone or misoprostol for some indication, but really lying, that's a very serious issue. That's a very serious ethical issue that is not so much related to abortion as it is to that person's lack of ethics. And if they're doing that with abortion, they're probably doing unethical things in other parts of their lives. But I think that if we simply allow people to continue to allow clinicians to do the best thing for their patients, it is not something in question. You have a clinical rationale for everything that you do.
We have two more questions we'd like to get to before the hour expires. So in the interest of time, let's push ahead to a slightly different question. One of the common objections that you read in the media and among supporters of abortion rights is that these laws protecting unborn children, again, we'll take the Texas framework as our concrete point of departure, will force women to care, and I'm borrowing the language of the critics here just to make sure I capture the force of their criticism. They say it will force women to carry to term babies, unborn children, fetuses that have been diagnosed with what are described as lethal fetal abnormalities. And we should underscore the kind of ambiguity of that term, whether that means lethal with or without treatment. Sometimes that's unclear. But let's take the example of a child who will die very soon, certainly die very shortly after birth, as a matter of clinical certainty, to the extent that's possible. How should we think about that kind of a case in light of the laws that seek to provide enhanced protections for the unborn child against abortion as it's defined in this statute? Let's start. Actually, let's start with a patient's perspective. We'll start with Leah, and then we'll perhaps ask Dr. Francis to chime in.
Thank you. I think this is one of those cases where the law can set a framework of protection, but it can't actually confer dignity on either the child or the baby, and that takes broader cultural work. I know people who have chosen to carry a pregnancy that doctors urged them to terminate because in one case, there was no amniotic fluid. They didn't see a way the baby was going to develop lungs, and the pregnancy was taxing for the mother. She delivered early, and her baby, fairly inexplicably, from the perspective of her doctors, survived. And they were very grateful, but they didn't do it because they thought the baby was going to live. They took pregnancy photos together with their whole family because it was the only time they were going to all be together as a family, and made inquiries with groups like Now I Lay Me Down to Sleep that do bedside photography for stillborn children so that they could have whatever time they did together as a family. They've received a miracle, but that's not what every patient should expect. And that's not the pitch a doctor is making to a patient in that case. I think the real case to be made is just that we want to effect a revolution in culture that cares for families who are facing this kind of diagnosis in the same way we would if their child was already born, where we're not steering them towards ending their child's life, but asking them, how do you want to spend this time with your child? During one of our miscarriages, we had a baby where they just couldn't find the baby. We knew I was pregnant based on my blood tests, but it was a pregnancy of unknown location. And so we had this kind of indefinite amount of time before I finally miscarried. And I had to walk every 2 days to get a blood test because we had to make sure that it wasn't an ectopic pregnancy, that I didn't have to go to the emergency room. And I spent those walks every day talking to the baby, telling them about the playground I passed every 2 days that I knew this baby was not going to play on, because this was my time to be an active mother to the baby, and I wanted to spend that time in love.
That's a very, very beautiful reflection. I would say there's an extraordinary, as you alluded to one group, there's amazing practitioners like Elvira Paravicini at Columbia University, who's developed a kind of perinatal hospice isn't quite the right word, although there is perinatal hospice, of course, to help parents understand what it means to be a parent in this context and to care. And just to put in one, as a law professor, one very short pitch for the law as a kind of to shape the moral imagination, to shape the imagination of people, to a law that recognizes and declares the independent humanity and dignity of the unborn child works a kind of paradigm shift in the imagination to think about, okay, this is is my child who is present now. What are my obligations? What are my unchosen responsibilities? Also, what's my identity as a parent? And that defines the relationships of everyone around the parent, not just the immediate family, but everyone around them as well. So I would say that the law can, in fact, shape the moral imagination to work a revolution, a paradigm shift in understanding of what the unborn and who the unborn child is. And in fact, what's being called for, just to be clear, is a kind of, and we should think about it in these ways, is a kind of euthanasia, right? They're talking about a situation where you have an independent living human being who is destined to die, and you're being asked to intervene accelerate or to embrace that demise intentionally. And that's something that gets into the questions of intention that Dr. Shiro-Wubenhorst flagged for us earlier. Let's press ahead, Jessica, in the interest of time, to the final question, if we could. But you had something you wanted to say to our listeners before we did that.
Absolutely. So before we get to our final question, and you want to hang on for that, I want to take a moment to thank our panelists and all of our guests for attending. This has been a fantastic webinar, and we will be coming back with two more that are going to go more deeply into the patient practitioner relationship and policy.
So this is our exit question, and just in brief, if you would, and this reflects what we hope is the heart of our initiative here at Notre Dame, to try to do what a university can do to help support a landscape in which mothers and babies and families are loved and supported throughout all their stages of life. One of the things here is like not just leaving the mother and the baby and the family behind once the baby is born, but in fact, just to begin at that point to surround them with more layers of love and support, both through public and private mechanisms. So just very briefly, for our listeners and for our own work here at the University of Notre Dame, if our panelists could just very briefly say, what's the most important thing you think we should keep in mind as we try to join together to build a culture of life and a civilization of love in which mothers and babies and families, patients and doctors and communities are surrounded with the care and concern and protection that they deserve?
I think the major part that I see is truly it is a community effort, and it's about mom and baby, but it's about the whole family. And so that's why this whole idea of the abortion affects everybody, and it's so deeply disturbing and so destructive to everything, because it affects everybody and everything. What we can do here is we can affirm that there is, yes, a child, but there's also a mother and a father and a greater family, including physicians and everybody else who's around the family, and create this culture of life and love amongst all of this time that we can spend together doing it. Because if you don't do that, patients don't respond to it. That's what they respond to, as they respond to the love and the caring and the sense of community and family that you were able to create. And that's the only way you get really good outcomes, and you get people to buy into it and affirm life in that way.
Thank you, Dr. Calhoun. Dr. Francis.
Yeah, well, I would echo what Dr. Calhoun just said, and I think I would just add to that we face a real opportunity as a nation to better support women and their children, and as Byron said, their families. But we face a real opportunity to provide women and their families with the resources they need to give their children life. We know that the vast majority of women who choose abortion do so really out of desperation, because they feel like they don't have the support and the resources that they need, and they deserve to have that. And so I think we face a real opportunity as a nation to come together, regardless of where we stand on the issue of abortion, to say that women and their families deserve better than abortion. They deserve to have the resources that they need so that they can parent their children and raise their families. But I think, speaking, of course, my focus is on the medical profession. Being a physician, I think we face a real opportunity as a medical profession as well to restore respect for the dignity of all human lives to the practice of medicine. And I think it really started with the introduction of abortion into healthcare, which we know it has no place in the practice of medicine. But now we have a real chance to come back to, our roots, our medical ethics roots, and in the Hippocratic Oath, to respect the dignity of our patients and to restore that respect for the dignity of all human lives, regardless of their level of ability, of their age, of their level of dependency. And so I think that restoring that into the practice of medicine will then allow us to better support our patients as we care for them.
Mm-hmm. Dr. Wubenhorst.
Yeah, there's really not a lot I can add to what my colleagues have said, except that I do want to say, I think both of them are spot on about, it's no coincidence that the patients, the women who have the worst outcomes, are the ones who are from the most broken social situations. They have no support. They have no one to go with them to their prenatal visits. They have no one in their room when they're giving birth, which is terrible. And it's not accidental. I think that concomitant with the decline of the family and the breakdown of the family has been the what I would call decline in medicine, the loss of our Hippocratic values, and also an atomization. Physicians are rarely connected to the communities they're involved with, and I'm not saying that they have to be, but I am saying that there's a sense in which we can have this kind of Mayberry RFD view of what life was like in the 1950s, and I don't really know if that ever was true, but I do think that there's a sense in which we can be engaged in, as Dr. Francis said and Dr. Calhoun said, pursuing human dignity, and that transcends issues of race and ethnicity. And it's very much about, there's a lot that we can do as physicians to help promote healthy families. There's a lot that we can do with that. And that gets into the public health area. It gets into the policy area, of which you're very involved and expert in as well. But I do think it's this vision of contributing to human flourishing. And really believing that we belong to one another. And as balkanized as we are and as divided as we are, breaking that down, that is really the solution.
Thank you, Dr. Winners. And finally, Leah and your beautiful baby there. We'd
Yay!
love to close us out.
Yeah, what I think I would say is that abortion is talked about as though it's a singular issue. And what I think has been really the focus of this whole panel is abortion, casts into greater relief every other structural injustice that mother and children face. We've talked about how care for children who are dying reflects the way we care for those who are dying of old age, those who are dying because of a congenital disability later after life. We've talked about the way that the difficulty women face when seeing doctors for any reason is kind of heightened in pregnancy with the unique vulnerability that entails. And I've appreciated some of the questions or comments from people just about that we've been talking about this through the lens of mothers and children who are babies, but anxiety over how to care for a baby reflects the anxiety parents feel about how will it be possible to care for a child through their entire life. Women who are mothers already often cite as one of their reasons for seeking abortion that they're having trouble, hello baby, taking care of the children they already have. Those women deserve more, whether they're pregnant or not just for the sake of the child in their womb, but for the sake of the child they're already raising. And so hopefully every pro-life solution is one that makes the lives of women who aren't mothers better, because it's helping to ameliorate these structural factors that are making it hard for them to live a full and flourishing life.
Thank you so much, Leah, and thanks to Jess and to all of our extraordinary panelists and discussants today. This has been a great illuminating conversation for me. It illustrates, I think, the depth and breadth of the culture of life movement. It's not just about protecting, it of course includes protecting unborn children from lethal private violence, but that's just the beginning. It includes caring for moms and babies and families throughout the child's entire life, throughout the family's entire life. And it makes me optimistic that we'll be able to find a way forward that does prepare that landscape. It won't be immediate, of course, but also it makes me optimistic for the possibility of forging common ground with people who have very different views of what the law and policy of abortion should be. We can all agree that we need to care for mothers and babies and families within the legal frameworks within which we find ourselves. And I'm hoping that we'll be able to extend a hand of friendship across the aisle of disagreement and find common ground.
Friends, thank you so much for joining us. In our next panel, we will be exploring the patient-physician relationship and how we can think about this model of flourishing being really instituted in that relationship and in hospitals and practices to promote the flourishing of women and children and their families and communities. So from us here at the McGrath Institute and the DeNicola Center for Ethics and Culture, thank you so much for joining us. Have a great afternoon.